If you're enjoying this Med Prep to Go Step 1 podcast, you can now get the content along with the content of the Crush Step 1 podcast ad-free in one bundle. Just go to medprep2go.com and find our new subscription podcast called Med Prep to Go Step 1 Bundle.
Hi, everyone. This is Ted O'Connell. I just want to let you know that we have launched a Step 2 qbank podcast, very similar to our Step 1 qbank podcast. Each episode will have 3 questions so that you can study on the go. We are actively recording these and plan to release a new episode every 2 weeks. We're also launching a premium podcast bundle that will include ad-free access to USMLE Step 2 Secrets podcast, as well as early and ad-free access to all of our episodes from the Step 2 qbank podcast. So please go over to our website at medprep2go.com and check these out, or you can access them wherever you get your podcasts. Thanks so much.
Welcome to the Med Prep to Go Step 1 podcast. My name is Chris Breitigan, and I'll be your reader for today. If you enjoy the podcast, please share it with your friends, and like and subscribe wherever you are listening. Today, I'll be reading 3 biochemistry questions from our Step 1 qbank, beginning with Biochemistry 19. A 24-year-old woman is evaluated in the hospital for dyspnea, weight gain, constipation, and feeling cold, which have progressed over the last 3 weeks. She has been admitted to the hospital for 8 weeks for an exacerbation of Crohn's disease and has been gradually improving with parenteral nutrition and immunosuppressants. Past medical history is otherwise unremarkable. Vital signs are within normal limits. Physical exam is significant only for a well-healing abrasion on her left leg that she sustained when she bumped the edge of the hospital bed while ambulating in the hospital room. Laboratory studies indicate an elevated TSH and normal glucose. Complete blood count and chemistry panel are within normal limits. Echocardiogram reveals dilated cardiomyopathy. This patient is most likely experiencing which of the following micronutrient derangements? A. Chromium deficiency. B. Copper deficiency. C. Manganese toxicity. D. Selenium deficiency. Or E. Zinc deficiency. And the correct answer is D. Selenium deficiency. Selenium is necessary for the function of selenoproteins, which are critical in maintaining thyroid function and cardiac structural integrity. Selenium deficiency may therefore manifest with hypothyroidism and/or dilated cardiomyopathy. Immune dysfunction may also be observed. Individuals receiving parenteral nutrition are at elevated risk for selenium deficiency. Answer choice A, chromium deficiency, is incorrect. Inadequate chromium results in insulin tolerance and impaired glucose control. Patients with chromium deficiency may present with symptoms of hyperglycemia, including abdominal pain, urinary frequency, and polydipsia. This patient's normal glucose levels argues against chromium deficiency. Answer choice B, copper deficiency, is incorrect. Inadequate copper stores may present with brittle hair, fragile skin with depigmentation, muscle weakness, microcytic anemia, and osteoporosis. Genetic copper deficiency may result from mutations in the ATP7A gene, which results in inadequate copper absorption and is known as Menkes disease. Answer choice C, manganese toxicity, is incorrect. Manganese toxicity is typically seen in individuals who work in the mining industry or as smelters or welders. Excessive manganese manifests initially with psychiatric symptoms and ultimately progresses to neurological symptoms similar to Parkinson's disease. Obstructive lung disease may also be observed. Answer choice E, zinc deficiency, is incorrect. Zinc is required in the zinc finger motif of collagenase, which is required to replace type 2 collagen with type 1 collagen in wound healing. Because of this, zinc deficiency is predominantly characterized by impaired skin integrity and wound healing. In infants, this can manifest as acrodermatitis enteropathica. Inadequate zinc stores may also present with hypogonadism, alopecia, immune dysfunction, dysgeusia, impaired taste, and anosmia, impaired smell. This patient's adequate wound healing argues against zinc deficiency. Key learning point. Selenium deficiency can present with thyroid insufficiency and cardiomyopathy. Individuals who are receiving parenteral nutrition, who are status post-gastric bypass surgery, or who have other diet-related diseases such as phenylketonuria are at elevated risk for micronutrient deficiencies. Next question, Biochemistry 20. A 32-year-old woman presents to the clinic with complaints of recurrent episodes of abdominal pain, nausea, and vomiting over the past year. These episodes are often triggered by prolonged fasting or intercurrent illness. She reports muscle weakness and occasional palpitations during these episodes. Her medical history is unremarkable and she takes no medications. Her vital signs are within the normal range. Physical examination is unremarkable. Laboratory studies performed during an episode reveal blood glucose of 45 mg per deciliter, low ketone levels, and elevated serum free fatty acids. A fasting study confirms hypoketotic hypoglycemia. A deficiency in which of the following enzymes is most likely responsible for this patient's condition? A. Fructose 1,6-bisphosphatase. B. Glucose 6-phosphatase. C. Glycogen phosphorylase. D. Medium-chain acyl-CoA dehydrogenase. Or E. Pyruvate carboxylase. And the correct answer is D. Medium-chain acyl-CoA dehydrogenase. This patient's presentation of recurrent hypoglycemia, low ketone levels, and elevated free fatty acids during fasting strongly suggests a fatty acid oxidation disorder, specifically medium-chain acyl-CoA dehydrogenase deficiency. MCAD deficiency impairs the beta oxidation of medium-chain fatty acids in mitochondria, leading to reduced ketone production and energy failure during fasting, resulting in hypoketonic hypoglycemia. The accumulation of fatty acids causes elevated serum free fatty acids, and symptoms like abdominal pain, nausea, vomiting, and muscle weakness are common during metabolic crises. Answer choice A, fructose 1,6-bisphosphatase, is incorrect. Fructose 1,6-bisphosphatase deficiency impairs gluconeogenesis, leading to hypoglycemia, lactic acidosis, and ketosis during fasting. The presence of normal or elevated ketones distinguishes it from MCAD deficiency, where hypoketosis is a key feature. Answer choice B, glucose 6-phosphatase, is incorrect. Glucose 6-phosphatase deficiency, von Gierke disease, causes glycogen storage disease type 1 characterized by hypoglycemia, lactic acidosis, hyperlipidemia, and hepatomegaly. Ketone levels are typically elevated during fasting due to increased fatty acid oxidation, unlike the hypoketosis seen in this patient. Answer choice D, glycogen phosphorylase, is incorrect. Glycogen phosphorylase deficiency, McArdle disease, causes glycogen storage disease type 5, presenting with exercise-induced muscle cramps and rhabdomyolysis. Hypoglycemia is not a feature as glycogenolysis is impaired in muscle, not liver, and ketone production is typically normal. Answer choice E, pyruvate carboxylase, is incorrect. Pyruvate carboxylase deficiency impairs gluconeogenesis by reducing the conversion of pyruvate to oxaloacetate, leading to lactic acidosis, hypoglycemia, and developmental delay. Ketone levels are typically normal or elevated, and free fatty acid accumulation is not a hallmark feature. Key learning point. Medium-chain acyl-CoA dehydrogenase, MCAD deficiency, disrupts fatty acid beta oxidation, leading to hypoketotic hypoglycemia, elevated free fatty acids, and metabolic crises triggered by fasting or illness. Diagnosis is confirmed by acylcarnitine profile or genetic testing, and management includes avoiding prolonged fasting and providing glucose during illness. Question 3, Biochemistry 21. A 25-year-old graduate student presents to the outpatient clinic with a 9-month history of progressive fatigue, shortness of breath during mild exercise, and generalized muscle weakness that worsens with activity. He reports difficulty climbing stairs and occasional muscle cramps. His medical history is unremarkable and he takes no medications. Vital signs are within normal limits. Physical examination reveals mild proximal muscle weakness with 4 out of 5 strength in the deltoids and hip flexors. Laboratory studies show an elevated serum lactate level of 4.8 millimole per liter, normal being less than 2 millimole per liter, normal blood glucose, and mildly elevated creatine kinase. Electromyography shows myopathic changes. A muscle biopsy reveals characteristic ragged red fibers on Gomori trichrome staining. Which of the following enzymes are most likely deficient in this patient's condition? A. Alpha-1 antitrypsin. B. Carnitine polymidyltransferase 1. C. Glucose 6-phosphate dehydrogenase. D. Phenylalanine hydroxylase. Or E. Pyruvate dehydrogenase. And the correct answer is E. Pyruvate dehydrogenase. This patient's presentation, including progressive fatigue, exertional dyspnea, muscle weakness, lactic acidosis, and ragged red fibers on muscle biopsy, strongly suggests a mitochondrial myopathy. Pyruvate dehydrogenase deficiency impairs the conversion of pyruvate to acetyl-CoA, a critical step linking glycolysis to the tricarboxylic acid cycle in mitochondria. This disruption causes pyruvate to accumulate, which is then converted to lactate by lactic dehydrogenase, leading to lactic acidosis. The compensatory mitochondrial proliferation in muscle fibers results in ragged red fibers seen on biopsy as clumps of abnormal mitochondria. The elevated creatine kinase, CK, and myopic EMG further support a primary muscle disorder. Answer choice A, alpha-1 antitrypsin, is incorrect. Alpha-1 antitrypsin, AAAT, deficiency results from mutations in the SERPINA1 gene, leading to uninhibited neutrophil elastase activity. It is unrelated to mitochondrial function, lactic metabolism, or muscle pathology. Answer choice B, carnitine polymidyltransferase 1, is incorrect. This deficiency impairs the transport of long-chain fatty acids into mitochondria for beta oxidation. This leads to hypoketonic hypoglycemia, liver dysfunction, and muscle cramps, particularly during fasting or prolonged exercise. Patients may present with rhabdomyolysis, but lactic acidosis and ragged red fibers are not features, as the defect is in fatty acid metabolism, not glycolysis or tricarboxylic acid (TCA) cycle function. Answer choice C, glucose 6-phosphate dehydrogenase, is incorrect. Glucose 6-phosphate dehydrogenase, G6PD, deficiency affects the pentose phosphate pathway, reducing NADPH production and predisposing red blood cells to oxidative damage, which results in hemolytic anemia. It does not cause lactic acidosis, muscle weakness, or mitochondrial abnormalities like ragged red fibers, and CK is typically normal unless hemolysis causes secondary muscle stress. Answer choice D, phenylalanine hydroxylase, is incorrect. Phenylalanine hydroxylase deficiency causes phenylketonuria, which results in intellectual disability, seizures, hypopigmentation, and a musty body odor if untreated. Phenylalanine hydroxylase deficiency does not affect mitochondrial function, cause muscle weakness, or produce ragged red fibers, and lactic levels are normal. Key learning point. Pyruvate dehydrogenase deficiency disrupts aerobic metabolism by impairing pyruvate's entry into the TCA cycle, leading to lactic acidosis and mitochondrial proliferation, ragged red fibers. It is a hallmark of mitochondrial myopathies diagnosed through clinical presentation, elevated lactate, and muscle biopsy findings, with management focusing on supportive care. Those are all the questions I have for you today. Thank you so much for listening. Please check out medprep2go.com for even more high-yield questions from our Step 1 QBank, and feel free to check out our other podcasts such as Dr. Ted O'Connell's Crush Step 1. Friendly reminder that you can get this podcast bundled with Crush Step 1 completely ad-free. More details at medprep2go.com.